Family Systems Therapy with Alexia Rothman. I'm really glad to have you all here today. My name's John Olstead. I'm a business development manager at PESI, and I'm coming to you from PESI World Headquarters in Eau Claire, Wisconsin. And I will be your MC for today as we move throughout the day with Lexi. So before we get started, Lexi, I got a few housekeeping items I'd like to cover with everybody. First off, this is a one-day event. We're starting here at 9 a.m. Central Time. We'll conclude at 5 p.m. Central Time, US. So I encourage you to do your own math and whatever time zone you happen to be. We'll take breaks in mid-morning and mid-afternoon, somewhere around 11 a.m. Central, and then again 3 p.m. in the afternoon. Lexi will kind of pick where she'd like to break around those milestones. And we're going to take an hour and 10 minutes for lunch as well. Lunch break will start about 12:50 p.m. Central Time, and then resume again around 2 o'clock Central. There's a few features here that'll allow you to be able to interact with Lexi as we go. About a half an hour into our presentation, you'll see at the bottom of your screen a Q&A button that will open up, and you can submit your questions for Lexi there. And you can also look at all the other questions, which we encourage you to do because you might find other folks have similar questions as yours. And you can upvote them. So as a group, go ahead and upvote what is your burning questions or that you'd like answers for. And that'll help Lexi sort through quicker too to see what you guys are interested in. There's also a chat feature here today, and you can check there for announcements that come from us to you, information on CE, things like that. If you're having technical problems, how to reach us. And our superhero AJ behind the scenes here helping us with a webcast will be dropping those messages in for you. And speaking of CE and other great information and resources, make sure that you check out the event portal that you came in through today. You can find CE information. You can find other resources on IFS, other trainings that might be of interest to you as we go throughout the day, and you can check that out there. With that, Lexi, welcome to the program. It's great to have you.
Thank you. I'm so excited to be here.
Yeah, so I'll turn it over to you. The audience is all yours.
Thank you. Okay, let me get my view set up so I can see slides and you can see slides. And then we will get started. So let's see. All right. Hopefully in a minute, this will be good. Okay. Okay. So first of all, I want to say thank you to all of you for deciding to be here today to spend the day together. I cannot tell you how happy it makes me when I see emojis floating up my screen. So thank you for that. I feel welcomed. And it's also nice to feel that there are people out there and feel a connection. You should see my screen right now. It's tremendously exciting. Thank you all so much. Thank you. Thank you. Yeah, I'm really excited to be here. Just the IFS model for me is something that has been so profoundly helpful in my own personal journey and in my professional life. So sharing the model is really, really meaningful. Oh, you all, this is like a party on the screen. I can't even tell you. So thank you all. And as John said, we'll go 9 to 5 Central today. We'll have breaks 11 to 11:15, 12:50 to 2, and 3:30 to 3:45 in the afternoon. And I'll try to be as precise with those times as I can. And with the questions, for me, anytime during the day, please feel free to submit questions. And you'll notice a couple things happen with them. Sometimes I'll be able to stop within a couple of minutes and go ahead and address the questions. Other times, you may not hear me addressing your question. And if that happens, be aware that some questions that come in today, I'm actually going to be addressing in writing during our breaks. So if there are questions you're interested in hearing the answer to and you're not hearing me speak the answers, during our breaks, just check the Q&A. There'll be an answered questions section where you'll see little paragraphs that I'm going to write in response to as many questions as I possibly can. With this size audience, there's no way I'll get to all of them, and I'm sorry about that, but I would really like to provide you with as many answers as I possibly can. Okay, so final things on logistics. This is just letting you know that as professionals, you're responsible for how you use the materials that we talk about today, just doing so in accordance with the standards of your profession, and that conflicts of interest have been disclosed in your program materials. But to make a long story short on conflicts of interest, there may be things that I mentioned today, various resources, maybe trainings, podcasts, book chapters, either if I'm asked or if it just comes to me that might be helpful. And in almost all cases, there is not a conflict of interest with the things that I mention, even if I'm included. So even if it's a book that I have a chapter in, or a podcast that I'm a co-host on, or a training that I'm doing, there's no financial incentive for me to mention any of those things. I don't get royalties from any of those things. So the only exception is if you went to my personal website and purchased something there, then I do get a percentage of those fees. So I might mention a lot, but very little of it has anything to do with me financially. Okay, so before we dive into the model itself, I would just like to say a little bit about what IFS, or internal family systems, actually is. And in my view, it is an incredibly useful and effective model for understanding how our emotional and our psychological systems are organized and how they operate. And it's also an empirically validated psychotherapy that we can use to help our clients with the full range of clinical concerns. And what you'll see as I talk to you about IFS theory and techniques today is that both the theory and the techniques of this model really look very simple, at least on the surface. So the concepts are very intuitive with IFS. We don't have a lot of jargon. And what's nice about that, I think, is it makes this a model that's very approachable right from the beginning for us as therapists and practitioners, and also for our clients. It is also a very comprehensive model of psychotherapy, which means it includes a whole lot of elements that you will find and that you may be familiar with from many other approaches. IFS incorporates a whole lot of really helpful elements into one very simple package, basically. So I'm going to say a little bit more about that, just give you a little sense of my history with the model, and talk about a little more about why I feel like it's such a comprehensive approach. So for those of you who haven't trained with me before, I'll say I've been a therapist now for 25 years. April will be 25 years since I saw my first official therapy client. And over the years, I have been exposed to a lot of different therapeutic approaches, theoretical orientations, so different ways of understanding my clients and working with them. And I began my journey here in Atlanta, Georgia. I'm actually from New York, but I came down to Atlanta, Georgia, where I am right now, to attend Emory University as an undergraduate, and that's where my undergraduate training began. And then I went out to the University of California, Los Angeles, to UCLA, to do my doctoral work in clinical psychology. So that was sort of the beginnings of my professional journey. But for a long time, when I was doing therapy, the first 11 years that I was doing therapy, I really considered myself a very integrative practitioner. So I was working from many different models and integrating elements that I saw that felt, were fitting for each client. And I really liked that way of working, because I still believe to this day that there's not one answer. There's not one way to approach our work with our clients. I might be super incredibly passionate about IFS, and that may be my default modality, but in no way do I want to make it seem like IFS is the only thing and it's the best thing and it's all we need. I think it's more accurate to say that different things will work for different people, or at different times for different people. So I very much love the integrative approach, and I see you all can relate to that too. So thanks for the feedback. And so I really enjoyed working in this integrative way. So I knew, okay, if I'm ever going to work primarily from kind of a therapeutic home base, particular orientation, it really needs to be one that's going to integrate all of what I have appreciated about the other models that I've found to be so helpful and so valuable. So I worked in that integrative way for about 11 years. And then I encountered a period of time in my private practice where I was working with several individuals who were survivors of very, very severe, very extensive childhood trauma and torture. And whereas I had worked with other trauma survivors for many years by that point, these particular individuals were not those who may be able to come in and earlier in treatment disclose what had happened to them, the full extent of what had happened to them. For many reasons, they could not do that. Many reasons that to me made a lot of sense. One, because they were still embedded in very dangerous, secretive external cultures, and it would have been a risk to disclose. Two, because they had every reason in the world to not trust anybody, including me. And so very appropriately so, they were very cautious in what they said and when they said, but also the reason they couldn't just come in and say, hey, here's what I'm holding, is because a lot of the material was actually walled off within their own psyches for protection. So they did not have full conscious awareness of everything that they had ever experienced that kind of contributed to how they were feeling and the symptoms that they were having. It was not all up in their conscious awareness. So they couldn't have, even if they trusted me, even if it had felt safe, they couldn't have really shared everything. And to me, that makes a lot of sense. It's a really brilliant adaptation of our psychological system that sometimes we can keep things out of awareness so that we can survive, so that we can function. And that was the case for these clients. So we worked together for a number of years on other material that was accessible to them, that didn't feel quite as overwhelming. And then eventually, some of what was buried began to surface. And at first I thought, oh, this is really good. I had the sense that they were holding more than we have been actually working with. And this is great that now they can share this with me and it's on the table. But it was sort of a mixed bag. And many of you may absolutely know this from your personal experience or your clinical experience, that as the material that had been buried for good reason, because it was very overwhelming, as it began to surface and they began to take the risk to share it, what actually happened was not improvement, it was a worsening of their symptoms, basically. So suicidality increased, self-injury increased, dissociation, addictive behaviors. And two of these individuals would have qualified for a diagnosis of dissociative identity disorder, of DID. And for me, that felt new. It may not have been new for me to work with individuals with DID, but I don't think I had the awareness and the knowledge before. And in these cases, it was very, very obvious because they would be speaking to me very much as an adult and suddenly be very much a child. And it was something I couldn't miss. So I felt out of my depth. I felt the need for more training, more supervision, consultation. So I started by going to the International Trauma Conference in Boston that Bessel van der Kolk hosted for many, many years. And it was there that I met Dick Schwartz, who is the developer of IFS. And he did, very much like we're doing today, he did a one-day workshop on IFS that I attended. And I immediately fell in love with the model. And this takes us back to the idea of the model being very comprehensive. What I saw in IFS, and I still do, was that it included so many of the elements that I had found so helpful with other models and wrapped them in this total package that was very comprehensive and also very simple on the surface and intuitive to grasp. So what I feel IFS includes is the mindfulness component, which is so important, the emotion focus, attention to the body and what the body is holding and the ability to work with that, the power of the therapeutic relationship, and not just the therapist-client relationship, but also the power of the presence that the therapist can hold in terms of facilitating a client's healing. Also the merits of attachment theory. And it's attachment theory not just applied to the client and their external relationships, but also it's attachment theory taken internally between the self of the client, which we'll talk about soon, and the various parts of their system, forming secure internal attachment relationships is a big part of IFS. It also includes the beauty of the hypnotic trance state or a similar type of state for healing and for connection, the wisdom of systems thinking, the power of loving kindness, effective ways to reprocess traumatic memories, spiritual elements, if that's something that's desired by the client. So all of this and more, I noticed, oh my gosh, this is all here. And so it was something that really drew me to this model. And also the fact that it is a non-pathologizing, very, very compassionate way to relate to ourselves and to teach others to relate to themselves. That was incredibly appealing to me because we all work with individuals who are in great pain. And the idea of helping them be able to look upon themselves and relate to themselves with compassion is to me like most everything. So like I was saying before, I absolutely understand there are a lot of beautiful and effective models for working with trauma, for working with the full range of clinical experiences. So if you're using a model that you love, that's really effective, it's working great with your clients, then the beauty of IFS is if you happen to like anything that I say today, if anything lands with you as, yeah, that's worth considering, you can just start to weave it in with what you're already doing. And then if down the line you decide you want to go more full force into IFS, of course, that option's always open to you, but it's not an all or nothing thing. I really feel like the IFS way of viewing the mind and the psychological system, that way of viewing things can be woven in with anything, and even many of the techniques can accompany other models. And of course, it's a very powerful model, and I'm hoping you're going to see some of that today. Many of you are probably already familiar with IFS, and you may have personally experienced the power of this model in your own work or with your clients. But for those of you who are newer, hopefully you'll see some of that by the end of the day. So what I'm hoping that we're going to be able to do together, it's a tall order, but I think we can, is talk about the origins and the development of the IFS model a little bit so you get a sense of how it started, talking briefly about some of the research support that we have for IFS, discussing the basic fundamental principles of the model, concepts, assumptions of the model, so that you feel that you have a very solid grounding in the fundamentals of IFS theoretically. And we're going to do that in the morning before the lunch break, get a lot of theory pretty solidly, I hope. And then in the afternoon, we transition from theory to clinical application. Okay, how do we take all of that theory we talked about and how do we actually put it into action? How do we use it with our clients to try to be helpful to our clients? We'll have the chance to do a brief experiential internal exercise to take some of the concepts into our own system and relate to them internally a bit. I wish there were more time for experientials because I know it's a fantastic way to learn by taking something in. Just because of the ambitious nature of the program, doing theory and application in one day, we are limited to one. And the way that I'll do things is, like I said, theory in the morning, application in the afternoon. And in the afternoon, the way we do the application is I will teach you several steps of the IFS protocol and explain them in detail. And then I will show you those steps in action by showing you segments from a video of Dick Schwartz, the developer of the model, actually doing the therapy with a real client where he will go through those steps. So you'll hear about the steps, you'll see them on a PowerPoint slide, and then you'll see them actually being done. And then after you watch each video clip, I'll recap for you whatever is important for you to take from that particular clip so that you don't have to think while we're watching it. You can just experience the session. So hopefully that's a few different channels of learning we can use today. So we'll start with how did this model get developed? So IFS was developed over 40 years ago now by Dr. Richard C. Schwartz. Dick Schwartz is how he's commonly called, so I'll refer to him that way. He was originally a structural family therapist. And as a structural family therapist, what he was trying to do at the time is really help family members learn to interact with each other in healthier ways. And at the time, that was his goal. He was not paying attention to intrapsychic work, to exploring a client's thoughts and a client's feelings. And he also didn't consider the past to be very important at that point to a person's healing. And additionally, and this always makes me laugh given how important we now know this is, but additionally, when he was first developing IFS, he placed no emphasis on the therapist-client relationship. And in the decades that follows, we have learned that the therapist-client relationship is perhaps the most important factor in how well therapy proceeds. And so at the time, though, he didn't emphasize that. I will say that has all shifted. IFS has a tremendous emphasis on the importance of the therapeutic relationship, the presence of the therapist. We get now how important that is, transference, countertransference, all of that we incorporate. But the reason I mention that that was not included when he first developed the model is it did do something positive, which is that it placed the emphasis on the self of the client as the agent of healing in the therapy. So whereas therapists are very capable of holding a really healing presence, and if we bring our healing energy and our healing presence to the therapy space, it definitely helps the client be able to access their own healing energy and capacity. So our healing presence is very important, but ultimately IFS theory believes that it is the client who will heal themselves. The wounded and burdened parts of their system will be healed by them, of course, with our help, but they are the healers. And that hasn't changed. So now, even though we recognize therapist is important, therapeutic relationship is important, still we believe that the clients will bring healing to their own systems. And also he learned that he couldn't really ignore the past because there are reasons that people's emotional systems have taken on the configurations that they've taken on. There are reasons why parts of them are in the roles that they're in. Real things have happened to people, people have suffered, and their past has influenced how their system shows up presently. So now we absolutely take that into account instead of separating a person from their context. So Dick originally developed his work in the context of his model in the context of his therapeutic work with clients with eating disorders. And what he noticed as he was talking to them about, why they were starving themselves, why they were binging and purging, they would very often mention what they called parts of themselves. So they would say things like, a part of me feels like I need to be empty, I need to be small, I need to be invisible. And at the same time, another part of me is saying, hey, you can't keep restricting like this. You're not going to be able to do your work. You're going to lose your job. You're going to get sick, or part of me wants to eat everything in sight. And another part of me gets really anxious and I just have to get rid of it. So people, at least in American culture, we tend to speak this way. Part of me this, part of me that. It's kind of typical way of speaking for many people. But he was making note of this. That's interesting. And then he worked with a client that he calls Diane. And I actually want to read to you his own words about what he learned while he was working with her, because I think it will give you in sort of a case study format. It'll give you an overview of the concepts that we're going to really drill down into didactically, afterwards. So Dick says, we all know about those luminous moments of clarity and balance in our own lives and in those of our clients, which come briefly now and again. However we get there, we suddenly encounter a feeling of inner plenitude and open-heartedness to the world that wasn't there the moment before. The incessant, nasty chatter inside our heads ceases. We have a sense of calm spaciousness, as if our minds and hearts and souls had expanded and brightened. Sometimes these evanescent experiences come in a bright glow of peaceful certainty that everything in the universe is truly okay, and that includes us, you and me individually, in all our poor, struggling, imperfect humanity. At other times, we may experience a wave of joyful connection with others that washes away irritation, distrust, and boredom. We feel that for once we truly are ourselves, our real selves, free of the inner cacophony that usually assaults us. For much of my life, the closest I'd come to actually experiencing this kind of blissful oneness was on the basketball court. Over the years, I'd become addicted to basketball because of the fleeting moments when I entered into a state in which my inner critics disappeared and my body seemed to know just what to do. I had total confidence in my abilities and experienced a sense of joy and awe at being spontaneously in the moment. When I became a family therapist, I longed to experience something similar with my clients. Instead, my work seemed hard, frustrating, and draining. I believed that it was up to me to restructure families, to use the force of my personality to pry apart enmeshed relationships and open up blocked communication patterns. I thought I needed to change clients by pure force of intellect and will. I had to come up with reframes for their symptoms, solutions to their problems, and new perspectives on their dilemmas. And then I had to find a way to motivate them to do the homework I gave them and to not feel totally frustrated when they didn't. All this responsibility for creating change and doing it quickly not only precluded any peak experiences in my work, it was burning me out. And then in the early 1980s, I began noticing that several clients with eating disorders described extensive internal conversations with what they called different parts of themselves. When I asked them about what happened inside them to make them binge and purge, I was intrigued. I had one client, Diane, ask the pessimistic voice that she was describing why it always told her that she was hopeless. The voice responded that it said she was hopeless so that she wouldn't take any risks and get hurt. It was trying to protect her. This seemed like a promising interaction. If this pessimist really had benign intent, then Diane might be able to negotiate a different role for it. But Diane wasn't interested in negotiating. She was angry at this voice and kept telling it to just leave her alone. I asked her why she was so rude to the pessimist, and she went on a long diatribe describing how that voice had made every step she took in life a major hurdle. It then occurred to me that I wasn't talking to Diane, but to another part of her that constantly fought with the pessimist. In an earlier conversation, Diane had told me about an ongoing war inside her between one voice that pushed her to achieve and the pessimist who told her it was hopeless. Could it be that the pushing part had jumped in while she was talking to the pessimist? I asked Diane to focus on the voice that was so angry at the pessimist and ask it to stop interfering in her negotiations with the pessimist. And to my amazement, it agreed to step back. And Diane immediately shifted out of the anger she'd felt so strongly seconds before. When I asked Diane how she felt toward the pessimist now, it seemed like a different person answered. In a calm, caring voice, she said she was grateful to it for trying to protect her and felt sorry that it had to work so hard. Her face and posture had also changed, reflecting the soft compassion in her voice. From that point on, negotiations with the inner pessimist were easy. I tried this step-back procedure with several other clients. Sometimes we had to ask 2 or 3 voices to not interfere before the client shifted into a state similar to Diane's, but we got there nonetheless. When they were in that calm, compassionate state, I would ask these clients what voice or part was present. They each gave a variation of the following reply. That's not a part like those other voices are. That's more of who I really am. That's myself. So before we move on, I just want to say, if you liked those paragraphs that I just read to you, you can access the full text of that article for free online. It's called The Larger Self by Richard Schwartz. And there's more to it than the pieces that I just read. So as a result of conversations like that between Dick and his clients, he began considering this idea, exploring this idea that people have an inner wisdom that could become a source of healing. And we know that many esoteric religions of the world and spiritual traditions of the world have already known that thousands of years before Dick Schwartz was wondering about it. So this idea of this calm, wise, healing essence that we have at our core, this is not unique to IFS. This is not an IFS, exclusive thing. This is wisdom of the ages. We know this. But what Dick was, as he puts it, what he just happened to stumble upon was a way to help people relatively efficiently access this place within them and then connect from this healing place, this healing core essence, connect to the wounded and the burdened parts of them so that they could heal themselves. So that's what we're going to be talking about throughout the rest of the day is what is this self in IFS? What are these parts? And how can we help clients access this presence and this energy and be able to heal their system in that way. So the article that I just referenced, it was called The Larger Self by Richard Schwartz, and you can find it, I believe, on the IFS Institute's official website and maybe posted elsewhere, but I believe it is on their official website. Okay. So that's what we're going to be doing the rest of the day. The one little detour that we have to take now is through the world of IFS research, because some of you may have an interest in some of the emerging empirical support for this model. For those of you who really don't have much of an interest in hearing about the research support, it probably will only take us about 15 minutes. So it's not going to last forever. But for those of you who are interested, I'm providing you with this website right here, foundationifs.org. This is the website for the research arm of IFS. And the reason I'm giving you this website is because as I start to talk about the research, some of you might find yourselves with questions like, oh, I wonder if there's been any research with IFS and this population or that population or this type of a clinical question or that type of question. So if you have questions like that, I wonder what else has been done. And has anyone looked at this? Has anyone looked at that? My answer to all of those questions is if you go to this website, there is a searchable database on the website of everything that has ever been done with IFS research. So you can put in your search terms, the populations you're interested in, the questions you're interested in, and see what's there. So in the interest of efficiency, that's the best place to find the answers. Yes, I'm just taking a look at some of the questions here. I see a question about DID. I will have a little slide on that later, so I can talk more about that then. And in terms of how, I see a question about how IFS may work well with EMDR. And so I have two things to say about that. One is that, first of all, I'm not EMDR trained, so I will just say as much as I know, and then I'll give you a better resource than me to answer the question. But one thing that a lot of people who've done EMDR work have noticed is that it is a very healing and effective modality. And the one thing about it is that it can progress, very quickly, right? Clients can end up accessing things quite quickly, and sometimes that can be disturbing to the system. We'll understand that more in IFS terms when we talk about our protective parts. And so what some people have found in terms of combining IFS and EMDR is that if they first use the IFS to help get the permission of what we call our protective parts, then they're able to go do some of the deeper trauma work with less backlash, is what we call it in IFS, or abreaction. So the work can proceed more smoothly if they use IFS to kind of form relationships with the protective parts and officially get permission to do the deeper work before they proceed. And then they can use IFS or EMDR. Now, as far as a better resource than me, there is a book that was published in August of 2023 called Altogether Us. It's an edited volume, and there are different chapters in that book written by different people with a lot of expertise with IFS. And I believe you'll have to check Amazon for the table of contents for that book. But I believe that that's what I'm thinking of now, that I believe that it is in that book where there's a chapter talking about the integration of IFS and EMDR. And also, I believe some people do workshops on that as well who are trained in both. Okay. So I'm gonna, let's see, gonna hold on some of these questions right now and then come back. I just want to say one more. So I see a question about, oh, good. So somebody's saying I've used IFS that way with EMDR and it has been really helpful. Great. Thank you for that. It's always good to know from somebody who's actually done it. And so somebody's asking too, I was wondering about doing IFS with clients who live with borderline personality disorder, and has research on this been conducted? As far as I know, there has not been research on that population, but there is an article that Dick Schwartz wrote. I believe it's something called maybe Depathologizing the Borderline Client or something like that, which is really nice because IFS, like I said before, is a non-pathologizing approach, a very compassion-oriented approach. And so I have found it to be unbelievably helpful with those who might officially qualify for a diagnosis of borderline personality, just a very compassionate and effective way to approach what's going on in their internal systems. But I believe there's an article by Dick Schwartz around that. So if somebody ends up Googling that and can find that and put the link in the chat, that would be great for everyone. Okay. And yes, somebody's saying I can only attend for 4 hours. I can assume I can go back and get the link to today's program and pick up the rest. This will be available for 14 days after. It's only if you want continuing education credit that you for the live workshop that you need to attend live in its entirety. But for the content, yeah, it'll be available. Okay, and I'll get more questions in a bit. So in 2013, the Foundation for Self-Leadership was launched with several main objectives, which is to kind of look at the effectiveness of IFS for helping clients with things like depression, anxiety, PTSD, even actually with chronic pain. Could IFS be an adjunct to medical treatments for conditions like rheumatoid arthritis, for example, and would it have any impact on the pain levels and the symptoms that people were experiencing of the physical disease? So the first randomized controlled clinical trial using IFS was actually published in 2013 in the Journal of Rheumatology. So researchers at Brigham and Women's Arthritis Center looked at the effects of IFS therapy on rheumatoid arthritis disease activity and also psychological status in a group of 79 participants. Now, they were mostly white, middle-class, Irish Catholic women from the Northeast. So again, a kind of a specialized sample. We have to be careful about trying to generalize the results of this study to our broader population. But what happened in the study was there was the control group and the IFS group. The IFS group got 9 months of IFS therapy. So it was individual and group IFS therapy alternating each week. They ended up with 15 individual therapy sessions in the end. And the control group got mailed educational materials about rheumatoid arthritis symptoms and disease management. And the groups were evaluated at 4 points in time with the measures that you see here. And some of them were self-report and some were physician assessments of their rheumatoid arthritis symptoms, self-compassion, depression, anxiety. And at the end of the study, the IFS group showed significantly greater improvements than the control group on measures of joint pain, their physical function, their self-compassion, depressive symptoms, arthritis self-efficacy. And a year after the study ended, the IFS group had sustained improvements in their self-assessed joint pain and in their self-compassion and in their depressive symptoms. So considering that, you know, we as therapists, we know that if you've got more than 15 sessions with someone, there are things you can do to help really solidify and maintain gains. It was a pretty impressive outcome. I do want to acknowledge, though, because I think it's ethical and fair to acknowledge the limitations of research when we're talking about the good stuff, that there were also some limitations, some small and some that I consider significant to this study. So one of them is that nobody dropped out of the control group, but 82% of the treatment group completed, which means 18% of the treatment group did drop out because they had conflicts with traveling to the therapy appointments. So we're not quite sure how their data might have influenced the outcome. But to me, a far greater consideration that we must keep in mind is that the attention that was paid to the control group in this study was a lot less than what the treatment group got. So in an ideal world, and this has been rectified in studies that came after this one, but in an ideal world, IFS would have been compared to another empirically validated therapy, and the control group would have gotten that, so that at the end of the study, we could say, oh, it was IFS that performed either equally well to this other empirically validated therapy, or it performed better. Here we can't say that because we've got the control group didn't get another therapy. So was it IFS that was so fantastic? I hope so, and parts of me believe that, but empirically, I can't say that. I can say there was therapy and then there was no therapy, and those in therapy did really well. And hopefully some of that had to do with what was going on in the treatment. And if I can remember later to talk a little bit more, it won't make much sense now, but talk a little bit more about why we believe that maybe the IFS specifically was helpful. I will try to do that. And of course, we have to acknowledge in this study and in so much of the psychological and medical literature, insufficient racial and socioeconomic diversity of the sample. We cannot generalize this to our population, our broader population. So we have to keep that in mind. But nonetheless, the results of that study and also a bunch of others that were submitted were sufficient for the US Substance Abuse and Mental Health Services Administration to grant evidence-based status to IFS. So it is an evidence-based treatment. And the statement on their website, at the time it was, as a clinical treatment, IFS has been rated effective for improving general functioning and well-being. In addition, it has been rated promising for each of improving phobia, panic, and generalized anxiety disorders and symptoms, physical health conditions and symptoms, personal resilience, self-concept, and depression and depressive symptoms. So I'm about to tell you about a lot of studies that came after that further strengthened this statement. And the first I want to talk about is a pilot study actually that was published 2 years ago. And it was the first study that looked at the effectiveness of IFS in treating complex trauma. And so the Trauma Center at Justice Resource Institute collaborated with a group of IFS therapists to look at the impact of IFS treatment on PTSD symptoms and diagnosis in a sample of adults that had officially were diagnosed with PTSD, had severe PTSD symptoms, and they had a history of at least 2 types of childhood trauma. So it could be childhood sexual abuse, psychological abuse, physical maltreatment, and they had to have at least 2 in their lived experience to qualify for the study. So this was not a controlled study. We only had the IFS group, and they got 16 weekly 90-minute therapy sessions. And the group was assessed at 4 time points to look at their PTSD symptoms and diagnosis, depressive symptoms, what they called the associated features of PTSD, that things we see going along with PTSD, like affect dysregulation, for example, dissociation. And they looked at self-compassion also. So 4 participants left the study, but of the 13 that remained, only 1 of them even qualified for a diagnosis of PTSD by the end of the study. So there were significant decreases in symptoms of PTSD, in associated features of PTSD, decreases in depression, improvements in self-compassion, and on multiple indicators of interoceptive awareness. So attention regulation, self-regulation, body listening, these things improved significantly. So clearly, again, acknowledging limitations, we've got a small sample size, we don't have a control group, limited diversity in the sample. But for those of you who would like to actually physically read this study and analyze it on your own, the IFS Institute paid so that it would be freely available to anyone who wants to examine it, because journal articles can cost sometimes $40, $50. So this one, if you go to that foundationifs.org website, follow links, you can get the whole thing for free if you'd like to examine it. But what was nice about that was a small pilot study. But the results were so good that it basically paved the way for a much larger project that is still underway. So I don't have results of this, but I'll tell you what's being done. So on September 1st of 2020, so the 3.5 years ago, a new independent study designed to build on the previous study was launched at the Harvard-affiliated Cambridge Health Alliance Community Mental Health Center in Massachusetts, and it was called the PART study, which I thought was cute. So it's a randomized controlled clinical trial, 60 adult participants who have been formally diagnosed with PTSD. They were followed over a period of 2 years to look at the effectiveness of IFS versus a nature-based stress reduction program as a treatment for PTSD and also comorbid opioid use in a subset of the sample. So the data collection, I assume, is over by now and is in the process of analysis. When papers come out, because you know how that can take quite a while to analyze everything, write up everything, get it peer-reviewed, get it published. So if you check back either periodically with that foundationifs.org website or subscribe to receive their updates through their newsletter, when the data comes out, you'll be able to see what they found. And I'm very, very curious about this longitudinal work. But another study that you can get right now, if you'd like to, was done in 2016. I found it pretty interesting for a number of reasons, but researchers at Colorado State University and the University of Minnesota, they compared IFS with what they called gold standard treatment as usual. Gold standard treatment being empirically validated CBT and interpersonal therapy. So they gave some people IFS and some people randomly assigned either cognitive behavioral therapy or interpersonal therapy so that they could compare IFS. And they were comparing it as a treatment for depression in college women. So they had 37 college women with mild to severe depressive symptoms randomly assigned. In the end, 17 completed the IFS therapy, 15 completed the gold standard treatment. And not surprisingly, both groups got better. So there were declines in depressive symptoms in both groups. They improved in terms of their depressive symptoms. And there was actually no difference between IFS and the gold standard treatments in terms of how much improvement and also the rate of change. How fast did their depressive symptoms decline? Same. So that result is suggesting, okay, in this population, it looks like IFS is performing equally well as these gold standard treatments for depression. But what I found more interesting than that is there were some aspects of the study that might have unintentionally given a bit of an advantage to the gold standard group, and yet IFS performed equally well. So for example, 53% of the treatment as usual group started antidepressant medication, either immediately before or during the course of the study. And the IFS group didn't have that. So it's possible, you know, there's a lot of research to suggest that taking antidepressant medication can be helpful, at least for some people, in reducing their depressive symptoms. So the treatment as usual group got that extra help and the IFS group didn't, and yet they performed the same. Also, people in the treatment as usual group, 1/3 of them were getting group therapy as well. And again, there's evidence that group therapy can be a very helpful thing for at least some people who are dealing with depression. And 1/3 of the treatment as usual group got it, but not the IFS group, and yet IFS performed equally well. So I found those things interesting. Treatment as usual therapists were also more experienced. And some of the IFS therapists had only been doing IFS for less than a year. So, you know, like with any other therapy, there's a learning curve. So perhaps using more experienced IFS therapists, we might have seen, you know, an even better result for the IFS group. So that was curious for me. It was interesting. And finally here, one of the most recent published empirical studies involving IFS evaluated a therapy protocol that was based on IFS that was designed to treat internet addiction. And it was published in March of 2023 in the Journal of Psychological Science by a group of researchers in Tehran. And the IFS-based protocol that was used in this study was evaluated by 7 experts in clinical, IFS, behavioral addiction fields. It was validated. And the participants in the study were 35 Iranian people aged 18 to 59 who scored above 46 on Young's Internet Addiction Test, and they got randomly assigned to groups. So the experimental group got the IFS-based treatment. The control group eventually got treatment, but not until after the data was collected. And what they found, the IFS group got 10 therapy sessions over a month and a half, that the reduction in internet addiction scores was significantly greater for the IFS group than in the control group. And they assessed them right after they had their therapy sessions, and they saw, okay, the IFS groups has a significantly greater reduction in their internet addiction scores. And then they assessed them 2 months after the treatment ended, and the group maintained their improvement 2 months later. So the researchers were wondering, is it possible that the reduction of symptoms that we're seeing here, could it be in some way attributable to the fact that in the IFS therapy, the participants worked with the underlying emotions that were fueling the addictive behaviors, things like shame, things like worthlessness? Could that have in some way fueled the results? So I want to take a second to look at some questions just to see. Okay. Yes. Okay, this has been upvoted a lot. I'm extremely interested in getting certified through, and it keeps disappearing, through, hang on, I gotta find it again. I'm so sorry. My whole screen changed all of a sudden. Getting certified. Oh, through IFS, but I'm finding the trainings full. It seems very difficult to get into trainings. Any suggestions or thoughts? Yes, so this has been a complicated issue for a while. For a very long time, there were a small group of highly experienced IFS trainers that had been working with Dick Schwartz from the beginning. So we're talking decades. Excellent trainers who were leading the level 1 and above trainings. And initially, the model wasn't so well known, and so it was possible to accommodate the demand. And then all of a sudden, starting a number of years ago, the model exploded in popularity, and we had thousands and thousands and eventually tens of thousands of people wanting to get training, and this tiny group of super experienced trainers who did as much as they could, and they just couldn't accommodate the demand. So then the Institute developed a lead trainer program that's designed to, help other people become trainers so that they could offer more trainings to more people. But they've been trying to be kind of cautious about not just rushing everyone through the ranks and having the quality of the trainings decline. So there's been this catch-up period where they're trying to get people who are actually qualified to do this trained up properly. So there's been this lag. Now, at this point, a lot of trainings are opening up, like new ones all the time, because there are just more trainers available now. So it should start to become easier to get into trainings. But my heart goes out to people who have been on the list. Originally we had a waiting list, then we had a lottery system to see would that make it more fair. And they've been trying for actually years and haven't been able to get in. So as far as I know, a few weeks ago, I think they decided to maybe do away with the lottery system, and somehow, I don't know if now they're looking at how many times people have applied and trying to be fair to those who've tried so many times. I'm not exactly sure the new policy, but I do know there are a lot more trainings coming available now. So hopefully it will get better for people to be able to get in. In the meantime, because the official IFS Institute trainings are a big commitment, there are lots of other trainings that you can also do, like similar to what we're doing today. So today, what I'm going to take you through is the majority of the content of level 1. We're going to cover the majority of the content of the 14-day level 1. But I don't want to say that this is a substitute for that, because that would be completely inaccurate. There's a big difference. So content-wise, I'm going to tell you about it. I'm going to teach you about it today. I'm going to show it to you. So you'll have that content. The difference between what I'm doing here and what we do, because I'm also a trainer for the Institute for level 1s, what we do there over a period of 14 days is we deliver this type of content. Every trainer does it differently, but we deliver this type of content in smaller chunks and have you go into rooms and practice actually implementing the techniques while you're being observed by a program assistant who can help kind of tweak your technique a bit and answer your questions. So you get a lot of personalized attention that clearly I'm not capable of giving in this format. And so that's the difference. It's very experiential training. You're really working with your own system. You're practicing, you're getting help. And here you're getting the information, which I still hope will be helpful. And for those of you who go on from here to the level 1, I hope that having today will give you a grounding so that you go in feeling even more prepared. But there are lots of, workshops, either by myself, lots and lots of other people in the world are offering IFS workshops that can give you a lot of the information, and then you can do the experiential on top of that. Yeah, okay, these are good questions, but they will make more sense if I answer them later. Yes, yeah, really good. Okay, some of these I clearly see it's going to make sense for me to say more a little bit later. So I'll come back to them, because right now if I talk about it, I'll just end up repeating content. And this is just a slide on the limitations of that study, but it's easy to read. I don't have to read it to you. Okay, so now I'm excited, because now we actually get to move into the model and talk about IFS theory. How does IFS understand the organization and the operation of our psychological systems? So most of us, at least in Westernized societies, we've kind of been culturally conditioned to believe that we have one solid personality, one solid mind, and as though all of our thoughts and our emotions flow from this one place, like this monolith in the picture here. So we say things that reflect that mono mind view. We say, oh, this is my personality, and that's your personality, and that's their personality. Or we say, I'm an anxious person, I'm uncomfortable in social situations, I'm a procrastinator, I'm suicidal. This mono mind view is reflected in thoughts like that and statements like that. But going back as far as ancient philosophers in many different cultures, and in some of the latest discoveries in the field of neuroscience, it's just becoming increasingly accepted that that citadel, fortress view of the mind is just not accurate. So what IFS theory says is that our mind is actually made up of many different sub-personalities, and that's what IFS calls parts. And the reason that we use the word parts is only because it's a user-friendly term. It's not a technical term. So if you don't like it, it irritates you, it annoys you, your clients hate it, you don't have to use that term. Some people will say, I have different sides to me. I have different aspects of my personality. Feel free to use whatever feels right for you and your clients. Most people will end up saying parts eventually just because it's easy, but not necessary. But no matter what we believe these parts to be, what we notice when we're doing the work is that they behave exactly like people, like whole, real people. So they don't behave like unidimensional emotional states. So we can't just say, okay, there's my anger, and there's my anxiety, and there's my sadness, and there might be a part that's holding a lot of anger. Maybe that even uses anger strategically and has us lash out at people when they make us feel ashamed, and this part of us goes after them with a lot of anger. So it's associated with anger. But when we get to know that part, it's very much like a person. It has more than one emotion. It has reasons for feeling the way it does and for behaving the way that it does. And because these parts very much are like people, we get the best results if we interact with them as though they were whole personalities. If we treat them with respect and curiosity about why they're doing what they're doing and all of that, we get the best results. So this idea of the mono mind, I am this way, it can leave us feeling kind of confused and ashamed about who we are and how we are. So for example, one really common thing that you'll see clients coming in to treatment with, maybe many of us can also relate to this personally as well. But let's say a client comes in and they say to you, I know that my physical health is the most important thing I have. It's the most valuable thing that I have. And I really need to be taking care of it. I need to take better care of my body. I really need to eat better, foods that really are nutritious and that support me. I need to get some exercise pretty regularly. I need to have better sleep hygiene. And this is really important to me. And it is really important to them. You can see they're very passionate. They recognize the importance of their physical health and they're very passionate about it. And at the same time, that same client might find themselves behaving really differently. So they're really passionate about their physical health, but yet they're maybe eating a lot of foods that don't necessarily support optimal health and might be contributing to some disease processes. Maybe they're not exercising at all. Maybe they have poor habits around their sleep. And then that contributes, them observing themselves doing that contributes to them feeling bad about themselves and feeling ashamed. Like, what's wrong with me? I say I care about my health and I sabotage myself all the time. I do the total opposite. Like, I feel crazy. What's wrong with me? Why do I sabotage myself? Why can't I ever do what I say I'm going to do? And it's that mono-mind view that can make us feel so bad about ourselves and so ashamed. And then it's hard to help ourselves from that place. IFS, in appreciating the multiplicity of the mind, has a totally different perspective on this. So we would say, okay, so in this person's system, they've got one part of them that's really trying to protect them in a particular way. That part is aware that their physical health is important, and it tries to protect them by making them aware of their nutrition and their exercise and maybe making goals around those things and around their sleep. And they have another part of them that's also trying to protect them, but in a different way. And maybe this other part is aware of all the stress that they have on them and all the overwhelm from the financial pressure and the job pressure and the personal problems in their relationships and things that they're suffering out in because of the way society is structured and how that is impacting them. Maybe they have a trauma history that's coming up and they end up feeling real uncomfortable in their own skin a lot of the time. And this other part that's trying to protect them has realized that, oh, if I have them eat comfort foods, foods that maybe aren't very nutritious, but they activate the reward centers in our brain, that they feel better. The person feels better. Maybe not a few hours from now, but in the moment, they get some relief and they feel better. So that part's trying to protect them by bringing them some much deserved relief and pleasure. And so we really respect that in IFS. They can have a both and. Two different forms of protection can be happening in the system at the same time. Can we approach that with respect and with curiosity, not with judgment, not with shaming, and invite both those parts to be known and for the client to be able to work collaboratively with these well-intentioned parts of them. So that's what I love about this model. Non-judgmental, non-pathologizing, welcoming of all parts, working collaboratively, like in internal community. So we'll talk more about that soon. But so the parts of us are understood in IFS as subpersonalities residing within us, different people, different ages, they have different histories, different talents, different temperaments, different reasons for why they do what they do, and they form an inner family in a way. That's why we call it internal family systems therapy. And somebody asked in the Q&A before, like, what might be some of the differences between IFS and maybe other parts models. And I'm not trained in a whole lot of other parts models, but one of the things that we see as different is even if there are other models that acknowledge parts, sometimes they do it in a group way. So you may have like an inner child, your inner child, for example. Whereas in IFS, there are multiple young parts within us. Some of them are wounded, some of them are traumatized, some of them need healing, some of them are just happy and just lending their characteristics and qualities to our system. So we have a very, I guess it's very individualized. You can meet many different parts, young parts, older parts within you. Also, other models may not have the similar concept of the self, which is different than the parts. It's not that we're just made up of these parts. We also have the self, which is a different level of entity than the parts. And I'm going to describe that in detail later, because I see people, somebody asking, and this was upvoted a lot, whether the self was the soul and are parts typically emotions, or are they actions or beliefs? And I will say, yeah, in IFS, the self actually is kind of a synonym for what we might call our soul or our core essence. And the parts, it's not that they are emotions or are actions or beliefs, but they are associated with it. So one part of us might be associated with certain beliefs and actions. Maybe it's the part of us that has us lash out in anger when people try to shame us. Maybe that's one part of us who has that role in our system. So it's associated with anger. It's associated with the behavior of lashing out verbally, let's say. But we might have another part in our system that is very hopeless, and is kind of really down a deep well of loneliness and hopelessness. Very different energy to that part than to the rageful part. So we will understand more about that as I describe those. Okay. And so, okay, let's see, let me just check this one off. And a question too here is IFS used primarily with individuals or also in family therapy settings? IFS can be used in all different therapeutic configurations. So, many people use it with individuals, but there is also an adaptation of IFS for couples therapy that was done by Toni Herbine Blank. So her name is spelled Toni, and the last name Herbine, Herbine -blank, Blank. She developed a model called Intimacy from the Inside Out, and it is truly brilliant. It's an adaptation of all this IFS theory and techniques to couples work. And it is useful also in working with more than two people in the room, whenever you're working with multiple systems in the room. And there are people now working on IFS with groups and all of that. So there are two main categories for the types of parts that we see in our internal systems. We've got what we call the exiles, the group of parts called exiles, and the group of parts called our protectors. So the exiles are the parts of us that have been wounded, they've been traumatized, they're vulnerable, they carry unresolved pain. And the protective parts are the ones that help us manage our day-to-day lives, manage our interactions with the external world. And they're also trying to protect us against all of the underlying pain that's stored in our systems, that's held within our exiles. They're trying to prevent that from flooding us and impacting us. And I will go into detail on each of these categories. This is just an overview slide for you to have to kind of simplify it, and then we'll go into each category in more detail now. So the exiles, these are the parts of us that hold the feelings, the memories that are very difficult for us to be in touch with. So most of us find it really, really hard to be flooded with pain or with shame, with terror, with profound loneliness, with scary memories of things that have happened to us, certain kinds of physical sensations and feelings in our bodies that are associated with our traumatic experience. That's a lot to have at the surface. And so because it's so difficult for most of us to be feeling and experiencing and remembering certain things, the parts of us who hold these feelings and who hold these memories are called exiles, because that's what other parts of us try to do with them. They try to exile them, to encapsulate them and push them out of awareness, hide them somewhere, bury them somewhere in our psyche, behind a curtain, under a trap door, in a cave, under the ocean, literally try to encapsulate the pain and the memories and the parts that hold all that and put them away so that we can't be impacted by them. So that's why the parts that hold all this are called exiles. They get isolated or exiled within our internal system. And while that sounds like a really mean thing to do, to take wounded people and be like, get out of here, you're too much for me, it sounds mean. But that's not the intention of the parts that exile these other parts. It's a survival strategy. Sometimes the only way to survive and keep going when we've had a lot of wounding and a lot of hardship and a lot of pain and misfortune is to put that away somewhere so that we can keep putting one foot in front of the other. So it is a natural survival mechanism. And in IFS, at this point, we just want to be able to help people go and reconnect with these wounded and traumatized parts to bring them healing so that they don't have to stay in exile forever. And what we find is many of these parts, by the way, I do want to say thank you again for the emojis. It is really interesting to talk to myself all day. So when I see that, I know that you're there and I know that things are landing with you. And it really actually means a lot. So thank you. Thank you. And so, oh, you guys, I love talking to therapists. There's just so much compassion. Thank you, thank you, thank you. All right, don't make me cry. Okay. So these parts that are wounded, that are traumatized, they're often very young. And the reason for that is, we're wounded throughout our lives. Bad things can happen to us at any point. But when we're young, we don't have the same resources to cope with that. If something bad is happening to a 3-year-old, for example, they cannot get in their car with their wallet and their cell phone and drive to their therapist's office or escape the situation. They don't have the capacity to do that. They're stuck in the wounding situation and they continue to be wounded. And the only thing that they can do is find a way to separate themselves from all the overwhelming pain so that they can go to school the next day or do what they need to do, make it through, survive. Whereas adults have other resources externally, other people, money, capacities, and internally they have other resources for being with their own pain and wounding. So a lot of exiles are young, but yes, if anyone's wondering, you can have adult-aged wounded parts that do get exiled in the system. And they can be frozen in time at the point where they were wounded. And therefore, even though our protectors try to keep them out of awareness, the right stimulus in the environment can bring that wounded part right up to the surface. So if you think about a combat veteran, for example, who maybe has returned from a combat situation decades ago, they were in that situation decades ago, and they're oriented to the present, and they know they're here, and they know they're not still in the combat situation, but they're walking down the street with their groceries one day, and a car backfires as it passes them. And that sound, that stimulus, brings them right back. And suddenly, it's not just that they remember, oh yeah, a few decades ago, I was in a combat situation. It is alive in them in that moment. That part of them that survived that lived that, is active and flooding their systems right now. So they're feeling the same feelings that they felt at the time. They might even be seeing the sights, smelling the smells. It can become, quite an alive situation for them. So for any of our parts that are holding traumatic memories that have been exiled, the right smell, the right sound, the right headline in the news, the right look we get from somebody else, the energy of someone that we pass on the street can call up one of these parts, and suddenly we're feeling all the feelings that they're holding and maybe having their memories too, either explicitly or in our bodies. And so exiling works to a point to help us get through, and then we've got to do something else. So again, these protective parts that lock away our traumatized and wounded parts, they're doing it with 2 positive intentions in mind. One is, let's protect these wounded parts from getting hurt again. So they are locking them away to try to prevent the re-wounding of our exiles. And they figure, if I can hide them away, they're less likely to get shamed again, criticized again, abandoned again, neglected again. I'm going to hide them away so they're safe. The other positive intention of the act of exiling is to try to prevent the exiles from flooding us with what they're holding, with their memories, with their emotions, their very big feelings, with the physical feelings that can be associated with our traumatic experience. We can get flooded with actual physical feelings too. And so the protectors feel, let's keep them away. This way we don't have to feel all that. We can just keep surviving, functioning, doing what we need to do. We can be okay. But a couple of difficulties with locking away these exiles. They're not just their trauma. They're not just their wounding. They're like any other person who has experienced traumatic wounding. That person has experienced trauma, is impacted by it, is living with that impact, but that person is so much more than their traumatic experience. There is so much more to them. And the same is true of our traumatized parts within us. They often, when we meet these wonderful people inside of us that have been so hurt, these often little children inside of us that were criticized, shamed, abused, abandoned, neglected, we meet them and we do healing work with them. We find out these are some of our most innocent, open, intimacy-seeking parts. They have all these wonderful qualities, all the qualities that children have when children are allowed to grow up in safety, joy and creativity, spontaneity, all of that. Even though they've been wounded, they still have all that within them, especially if we can help them heal, those qualities start to come to the surface more. So this is my son, and you probably can tell from the eyes, it's my boy. And this was taken 8 years ago. Now he's, way bigger than me. He's almost 14. But this was at his holiday party in kindergarten. And he's showing me this little candy house that he created. And you can see, you look in his eyes, you see this openness for connection and this desire for approval, for affirmation, and the youthful joy about, I did something, look what I did. And my response in that moment, what I say, what I do in that moment when he's so open for connection, so vulnerable like that, the way my response is going to land with him is not, this is what mommy thinks about my candy house. My response will land as, this is how mommy feels about me, And so fortunately for me, fortunately for him, in that moment that he's showing me this so wide open, fortunately I was in a good place. So I was able to respond maybe in the way he needed. And I was excited with him and we had a nice interaction. But I do think a lot about what happens if I had responded differently. And all of us do at times, any of us who have had responsibility for children, none of us have been perfect, in our responses. We don't always show up with this beautiful energy exactly the way the child needs. That is not realistic. And fortunately, it's not even necessary. The research shows that if we can get it right and be fairly attuned about a third of the time, we're doing great. The kids will be okay. And when we don't get it right, we have opportunity for repair, and that's really helpful for the parts of me that do get sad that I'm not always perfect, when I'm interacting with anybody, especially somebody like a child who loves and depends on me. It's good to know we have some leeway. However, I think about with this, what if somebody never showed up for him in the way that he needed, and he would be open for connection and he was never met in the way he most needed, or he was met with abuse or ridicule or, rejection, shaming, at that point, especially if it's me who's doing it to him, especially if the one who's supposed to love us and protect us is the one that is doing the abandoning, the shaming, the criticism, which is the case for so many of us therapists, so many of our clients, that the ones who are supposed to love and protect us were the ones actually hurting us so much of the time. What's he supposed to do with that? And so as a survival mechanism, again, he would just sort of encapsulate that pain, that little boy inside of him that's holding all that, so that he could go back out onto the playground and, interact with the other kids in a way that felt safer for him. So naturally, these exiles long for connection. They want the connection and they're scared because it's often through connection that they've been hurt. So I'm going to take a look in the Q&A for a minute before we move on to protectors. Yeah, so if clients are able to talk about their traumatic experiences but feel nothing, would we look at that part as still being exiled and therefore feeling unsafe to feel? Yeah, so if clients are able to sort of talk about, yeah, this happened to me, and they're really numb, they can't feel it. Often, I don't want to say all the time, but often what's happening there is that there are protectors in their system who have taken on the role of being able to keep them numb and disconnected from the real pain of their experiences, because it was necessary to keep them numb and disconnected so that they could keep going. And so over time in the therapy, we are able to actually connect with these protectors that are afraid to allow the person to really feel, what's held inside of them. And we are very respectful of the fact that that has been a necessary strategy for a long time, and that the protector might be very wary about relaxing their guard and allowing the person to connect with the emotions underneath and the wounded parts underneath. So for some systems, that's a long journey of establishing that it could be safe to actually compassionately be present with the parts that were so wounded. Because right now, if they're feeling numb like that, there's not trust. So we still believe that there are exiles underneath who have been wounded, who did experience pain, are still holding that, but the person is not yet allowed to connect with that, which I think we have a lot of respect for. That was the way that they could do it. Oh, I'm so excited, Maureen. You're saying you could think of a specific adolescent you want to use this with. Yay. I hope so. I hope so. And yes, good enough mothering. Such a relief to my perfectionist parts when I learned about good enough. Have a hard time. Trust me, parts of me have a hard time trusting the idea of good enough, but other parts of me get that I can go with that. Yes, yes, yes. Hurtful experiences equal disrupted attachment and perspective about self, relationships, and the world around us. Absolutely. Absolutely. And that disrupted perspective about self, relationships, and the world around us. Hold on to that idea, because when I talk about the burdens that parts carry from their wounding, the burdens include those disrupted perceptions and perspectives about all of those things. Oh, this is a great question too. Is ADHD a part that can be healed? So for me, it's really important when we're talking things like ADHD or autism, for example, to have a both and perspective, because there are just some things that are wired into us that are part of our neurology, right? We come in to the world wired in a certain way, and that is real, and that's not a part that we can heal or that even needs to be healed or changed or fixed or in any way. This is who we are, you know. And we can also see parts related. So when I'm working with clients with ADHD, for example, some of, let's say, their distractibility is their ADHD, right? Just neurologically. Other times, in addition to that, it can be parts that have learned to distract them for certain protective purposes. Maybe the person gets very, very anxious, and a part distracts them because that helps relieve the anxiety. And so it looks on the surface like an attention disorder because the person can't stay with the tasks they have to do. But when we actually get curious to see how much of this is neurology, how much of this is a part, sometimes you get a part saying, yeah, I do this because we can't cope with the anxiety. So taking you out gives you a lot of relief in that moment. And similarly with autism, there can be parts that react, that feel upset about certain things, that feel frustrated with certain things, that we can actually work with. But the fundamental way the person is the way the person is and can be celebrated. So hopefully that's helpful. It's a both and situation. Okay. Yes. Okay. Oh, yeah. And this is an interesting question. I wonder if IFS can work with autism and masking. I have a client who refers to parts as outfits. Oh, that's so cool. Yeah, absolutely. We can get curious with, and when I talk about parts, it's going to make more sense. And when I talk more about protectors, it will make more sense that with regard to masking, for example, one way we can understand it is we can have a part of us, if we are autistic, we can have a part of us that is aware that we are safer in the social world if we learn some of the rules and we try to then implement that and act in certain ways and not act in other ways and hide certain of our behaviors that can be judged or whatever. And so those parts that are aware of those things and attempt to have us present in a certain way can be considered manager parts in IFS. Okay, so I'm going to talk a little bit about protective parts now. So our protective parts, we've got two categories of them. We have proactive protectors and reactive protectors. So managers, firefighters, and all types of protectors can have what we call extreme roles or preferred roles. So all of our parts have preferred roles in the system. Like they have things that they have special talents with, that they would like to do, lending their resources to our system in a valuable way. So I think for me about a part of me that I call the organizer. And it's a part of me that does exactly what the name says. It helps me keep myself organized, keeps my house organized, my schedule organized, my thoughts organized about what I might like to communicate with you on each of these slides. It is aware of the time. And so I have a part of me who loves to do that. It's a strength that this part has. She's probably pretty wired into my prefrontal cortex and all the areas involved with executive functioning. That part's probably got some real estate there. And so that's her preferred function. likes to do it. None of my other parts have a problem with it. There's not conflict in there about her doing her job. She just lends her qualities to the system that way. But IFS says that if we have traumatic experience, for example, a lot of wounding, parts of us that might have liked to just function in their preferred roles can bump up into more extreme roles where they're using their strategies in a much more extreme way that can actually bring us some negative consequences. So, for example, I had a client of mine a number of years back who also had in her system an organizer part, which she also called the organizer part. And we had gotten to know this part early on in her therapy. She had a pretty significant trauma history. So at first it didn't feel safe to go to some of her more traumatized parts. So we were trying to start with something that would be feel a little bit easier or safer on her system. So just asked her to identify a part of her that there was no conflict around, that she felt good about, that she would be allowed to get to know just to practice the steps of the model, basically. And she said, yeah, I've got a part that like helps me get good grades and keep my apartment clean. So I said, oh, let's get to know that part. So we befriended that part of her. And she said, oh, it likes to be called the organizer. It helps me do these things. Kind of knew that part and then forgot about it because we were working with other things for like a year after that. And then she had, during the course of our work together, some traumatic experiences happen to her. And one day she called me like days after something really bad happened, and she was in her apartment and she said, I can't come in today. I can't make it to the office. So I said, what's going on? And she said, I'm sitting on the floor she was on her knees, sitting on the floor on my knees in the corner of my bedroom, and I can't get up. And the scenario was that she had 5 pencils laid out on the floor in front of her, and she had to organize them in exactly parallel lines. And if she could get them exactly parallel to the millimeter, then she'd be allowed to get up and move. So you think, okay, that sounds like an OCD type process. Like she has to do this exactly right and organize this exactly right. Otherwise something bad will happen. That was the sense in her. Yes, it was very much like an OCD type process for sure. So I said, it's okay, let's talk to the part. And so I started interviewing that part, basically getting to know it using the steps I'll teach you later. And at some point I said directly to the part, she was letting me talk to it directly. I said, if you didn't have to protect her in this way that you're doing right now, what would you like to do in her system? And it said, well, what I always do, just help her get good grades and keep her room clean. And I thought, oh my goodness, this is the organizer part that we know already. And the traumatic experience had it bump up from the way it was protecting before to feeling the need to protect in a much more intense way. And so we were able to work with what had happened and all of this so that the protector could come down from that role. And I do say that to just illustrate the difference between preferred roles and extreme roles. I don't say it to suggest that you can fix OCD processes in one session. The only reason that this resolved so quickly in her system was because this protector had just bumped up into this extreme role. She wasn't someone who was coming to me after years and years of thousands and thousands and thousands of repetitions of this pattern, and then it went away in a session. That's not possible with any therapeutic modality. So I just want to acknowledge that. But it was an extreme role this part had just bumped up into, and we were able to work with it more easily as a result. So in terms of the protectors, I said there are proactive and reactive protectors. So the managers are the subgroup of protectors in our internal system that use their protective strategies in proactive ways, which means they use them to prevent 2 things from happening: exiles from being rewounded and exiles from flooding us with their emotions and their memories. So the managers use whatever strategies they know how to use to try to prevent those 2 things from happening to us. But again, with the whole preferred role, extreme role thing, if the managers didn't have to be so controlling and trying to keep us safe in all these ways, what they would like to do is just help us run our day-to-day lives, help us learn and grow and improve and get better at things and take care of ourselves and take care of others that are dependent on us that we'd like to take care of. They would just like to help us do that, like the organizer part. But when traumatic experience or a lot of wounding has bumped them up into an extreme place, that's where they can take on strategies that have good intention, but have negative results for us. So they can have us constantly and endlessly striving without ever being able to feel like we've arrived or we're satisfied or we're good enough, perfectionistic, criticizing ourselves, breaking ourselves down in all kinds of ways. I think I saw a question in the Q&A about that, where sometimes protective strategies can actually seem kind of self-destructive in a way. And yes, and I'll say a little bit more about that later. We can be criticizing other people, pessimism we saw in the example of Diane, that can be a proactive protective strategy. If I don't let you take risks, then you will not get hurt. In other words, I'm looking in the future. I don't want you to get hurt, so I will make you really pessimistic and think nothing's ever going to work out for you. Then you're not going to bother to take the risk, and therefore you're not going to get hurt again. So it can be proactive in that way, looking to the future and trying to prevent. Whereas the other subgroup of protectors, the firefighters, are reactive. So if the manager's strategies have failed, and despite everything they try to do to make us, protected, the exiles still get activated by something, which they will. Our stuff comes up inevitably, something activates it. Then the firefighters jump in, and their role is, oh my gosh, you're being flooded by the feelings, by the memories, by the body sensations of your wounding and your trauma. I'm going to numb that for you, or I'm going to disconnect you from that. I'm going to distract you from that. I'm going to help resuppress those parts so they don't come up. So these parts try to help us after the fact when we are being flooded, and they try to help us feel better in the moment. So the managers are looking to the future. I don't want anything bad to happen to you in the future, so I'm going to use my strategies. The firefighters are looking right now in this moment. You are upset now. You are flooded right now. You are uncomfortable right now. Let's go binge eat. That's going to help right now. The manager might be saying, no, don't do that, because you have diabetes, and in the future you might lose a leg. The firefighter doesn't care. It's right now. You are not feeling good, and I know a way to help you feel better right now. So I'm going to help you. So if you think about the name firefighter, it makes sense, right? In the real world, the function of a firefighter, a person who holds that job, is rush in when there's a fire and put the fire out. However you need to, pour water on things, break down doors, pour chemicals on things, whatever you need to do, get the flames out. And you cannot be concerned with collateral damage when you're doing that. If you have to break down somebody's antique door to get through to save their life and to put the fire out, that's what you're going to do. If you have to pour water on their family photo album and their art collection, you're going to do that. Collateral damage doesn't matter. Get the fire out. Here's the same thing. The fire is the exile activation and all the discomfort that brings. And then the firefighter comes in with all of these strategies, drug abuse and self-harm and raging or procrastinating or oversleeping, dissociating, comes in with all that, because in the moment that helps us feel better, brings some regulation in a weird way to our system. It does. Cannot be concerned, though, that there's a million types of collateral damage that go along with any of these things, with abusing alcohol or drugs or harming ourselves, or lots of different things we can do with food, or money, or anger. All of these things can have negative consequences for us, but that's not what they're concerned with. They're concerned with, in this moment, how do I help you feel better? But they have preferred roles too. If they didn't feel like they had to protect us this way, what they would like to do is bring balance to the internal system. So the managers in their preferred roles, like I said, are helping us take care of things and take care of ourselves and learn and grow and improve and develop our skills. And that takes work. Even if they're in preferred roles, it takes energy, it takes effort. So these parts would like to come in and say, hey, it's good to rest. We can have some rest. We can have some fun. Let's do something new, have an adventure, or just sit with a cup of tea and a nice blanket by the window. That's what would be considered harmony and balance in the internal system. If the managers were doing their thing, the firefighters in their preferred roles were doing their thing. So we had work and play, rest and effort, balanced beautifully. That's what we're looking for. But that is not what brings clients to therapy. They don't come to therapy when their systems are in harmony and balance, and they are both achieving and resting and playing. They come when one or more, usually more than one of their parts have bumped up into a more extreme place, and the methods are having some consequences, and then they're troubled by that and they come in. So again, the firefighters are impulsive, and because of this, because their methods can have negative consequences, they are not loved internally or externally. Our managers get loved. Inside our system, our other parts are like, oh, I'm so grateful that you have me exercise, or I'm grateful that you have me be conscious of, taking in some good nutrients every day, or drinking enough water, or trying to save my money. Inside, other parts they feel safe that the managers are helping with those things. Externally, people compliment us for our manager-driven behaviors. Oh, that's so great that you work out a few times a week. That's so great that you save for retirement. I really admire that. But they don't do that with our firefighter behaviors. They don't come up to us and say, I have so much admiration for the way that every month you spend way more than you earn, and you're in so much debt. That's so admirable. Nobody says that. Nobody says that. And thank you for the emoji. And internally too, we have the same thing. Like, our parts are really resentful of the parts of us that get us in trouble. If we have a part that overspends, guaranteed we have a part that doesn't like it. If we have a part that overeats, if we have a part that has to starve ourselves, if anything extreme, we've got another part that doesn't like it. So I'm going to give you a little hypothetical. I know this slide is blank. It'll be blank for a couple of seconds here. A little hypothetical clinical example to just bring this together here. So if you imagine in your practice that you have a therapy client named Joe, a female client named Joe, who was really bullied growing up because of what she wore, because her family didn't have a lot of money, so her clothes were dated, they were out of fashion, they came from her cousin's hand-me-downs, they had holes. People made fun of her, they criticized her, and nobody supported her around any of this. So she held a lot of pain around this. And so somewhere in Joe's system is a school-aged exile. So there's a young girl that holds a lot of pain about not just how she looks, but pain about who she is, a lot of sense of worthlessness, because she had come to tie her worth, her self-worth, to her appearance, as happens so often in our society. So then when people were criticizing her appearance, she felt fundamentally bad about who she is. So over time in her system, a manager part has moved into a highly critical role. So this goes back to the person who asked the question in the Q&A about if sometimes protective behaviors can actually be sort of internally hurtful, critical, damaging. And yes, so what's happening in her system is a manager part is saying, you're unkempt, you're a loser, you're a slob, nobody's going to love you if you look like this. And that can be confusing when you're first learning IFS, because you're saying, wait a minute, this is a manager part. Managers are part of the protective system. And this sounds so self-destructive, so harshly critical. And this is where in IFS, we separate the intention of the part from the impact of the part's strategies. So the impact of this criticism is, it really hurts the person, and it can damage their self-esteem and all of this, and create lots of issues inside. But the intention of these parts is always positive. And we don't even just assume that, we actually get to know the part. So using the techniques I'll teach you in the afternoon, you'd have Joe befriend this manager part of her, and the part would say, I criticize you like this constantly because I want to keep you really aware of how you put yourself together. Because if you're very aware of how you put yourself together, maybe you won't make a mistake where somebody else is going to criticize you for how you look, because it's so much harder hearing it from someone else than it is for me to just say it to you inside and for you to try to avoid it. When someone else says it, it's so much worse. So the positive intention is, let me criticize you, you're going to stay more aware, you're going to do a better job of putting yourself together, and then maybe you won't get hurt in a really bad way from somebody saying something to you. But the sad thing is our managers can try their hardest and try to make us as perfect as possible, in every way. And this still happens. If somebody has a part in their system who, for whatever reason, would like to criticize us internally, to our face, publicly, we can't stop them. And they do that. And so this happens, there's a critical comment, cuts through all the layers of protection in Joe's system, and it activates the exile. So now all the pain and the shame and the worthlessness are just flooding her system. And again, who are the parts in our systems that go into action when we're already being flooded by what an exile is holding? It's the firefighters. So an exile is activated. It's flooding Joe with shame, worthlessness. And then a firefighter comes in and says, okay, we're just going to bring the energy way down in the system. You know, you're going to get into bed. There's no energy to do anything. You're just going to pull the covers over your head and shut the world out. So there's a firefighter literally depressing everything in the system, using depression as a strategy. We're going to shut you down, close you up. And in that state where she's got so little energy running through her body, she's not flooded anymore by shame and overwhelmed by it and all this worthlessness and all these thoughts. Everything's just sort of numb, disconnected, slowed down. And once this has happened a few times, this cycle, it doesn't feel good, right? Because a critical comment comes and suddenly she's not taking care of herself. She's not going to work. She's not interacting with people. You know, her eating is poor. So that something has to give here. So the manager starts to ramp up the criticism and the shaming, figuring, okay, well, if I can keep her even more aware of how she puts herself together, maybe she won't make the same mistake again and she'll be safe. But it doesn't work. So now another part moves into a firefighter role. So this is the retail therapy part. So now anytime the exile is activated, this part waves her arms and says, oh, distraction, distraction. There's a sale over here, you know, let's go shopping. And so for a few hours, Joe's out at the mall and she's trying things on and acquiring purchases and all of this. And she's blissfully disconnected from the shame and the pain and the overwhelm that was flooding her before. In the back of her mind, there's another manager saying, we shouldn't be doing this. We shouldn't be spending this money. We've got a lot of credit card debt. We should stop it, put the stuff back, don't buy it. But that part is not in the driver's seat of the psyche. And we're going to talk more about that later. That part is there. That part is voicing objections, this tiny little voice back here, but it is not in control. It is not driving. The part that's driving is the retail therapy part. So Joe is spending money and she is acquiring things despite the objections. Then she gets home and this retail therapy part has done its job. It disconnected her from the exile's pain. She's felt okay for a few hours. So that part unblends. And then this manager comes to the front, gets into the driver's seat, berates her. You're so pathetic. We set a budget for the new year and you blew through it. We're 2 weeks into the new year. You blew through your whole budget and then some for the whole year. You can't ever stick to any plans. You're so irresponsible. So then that part is here and it's criticizing her, again, with the good intention of trying to get her to do better so that she'll be safer in the future. So I put this picture up here to show you graphically, why do we call this internal family systems therapy? It's because we are never dealing with just one part, even when it looks like we're dealing with just one part in isolation. All the parts are connected to other parts in a web of relationships, the way that people in a family or community are. And I see you guys are you're getting it. Yeah, there are interrelationships there. So what happens with one part, as in any other system, affects other parts and they react to it. And so when I'm talking to you later about how to work with a part, I'm going to do some acknowledgement of, and as you work with that part, there can be interference from other parts, because any of you who've tried this model, you know that that happens. It's not so clean where you go to work with one part and you just stay with one part. You can have all kinds of interference. So we'll talk about that. So let me just check our Q&A again. Yeah. So I wonder how, as a therapist, you don't get overwhelmed keeping track of a client's parts. I can get overwhelmed with parts and which part we're working with. Yeah, it's a really good question, because there can be a lot of parts that could be surfacing at one point. As far as in my documentation, you know, we might move through a couple of parts during a session, but whichever part we end up spending significant time with, you know, at the end of the session, I will write, okay, we worked with this part, it was a protector, this was its strategy, you know, anything else we know about it, if we learned about its age or its positive intention. where we are in the process of developing a relationship between the client and that part, and then where we left off with it. But I won't necessarily document like the 50 parts that might have shown up along the way. Number one, it's okay if a part is a real significant player in the system. It will come back up and we'll have more opportunities to connect with it in future sessions. So we don't have to remember everything about everything. But if we've spent significant time getting to know someone, I do want to make note of that. And if there's a lot of parts coming up at the same time, and there's like many of them just all making noise at the same time, sometimes instead of trying to go down every little trail to talk to each little part, I might say, okay, let's pause for a minute here. There are a lot of parts coming up. Okay, let's just pause and acknowledge them all. Like as a group, just let them know you're noticing them all coming in here at this point. Just let them know you're seeing all that, you're hearing from them. Sometimes that pause and that acknowledgement as a group brings the energy down a little bit in the system. And then you can try to focus more and say, okay, we've got all these parts here. Just feel into it. Where does it make sense to go right now? And just let the other ones know we'll get to them if we don't today. And sometimes that slows it down enough that they'll say, yeah, let's just stay with the critical one, and then sometimes it'll help us refocus. I see that somebody says the slides are not in sync. Usually that happens on a one-by-one basis, like your computer may not be in sync, but for the most part they are. So if you put that in the chat, they may be able to help you with how to fix that. And in terms of mapping out parts over time, I don't necessarily usually keep maps of my clients' parts. Sometimes on my notes for that day, I'll map out the little cluster of parts we worked with. Like if there was a protector protecting a certain exile, and then it was polarized with another protector, I might make a little diagram on that. But my clients can do that. If they want to make little parts maps, sometimes we'll do it collaboratively or they'll do it. It's not something that I always do or that I feel like we have to do all the time, because what I notice, like I said, is the main players keep coming back and we work with them. And if I get too invested in, and relationships change internally between parts. So if I get too invested in making a map as though it's a fixed thing, then it's going to shift anyway, and that can itself be confusing. So, however, it makes sense for that client. Oh, the chat is disabled. Okay, I see. I'm sorry. So hopefully, AJ, who's monitoring the Zoom, can put some advice in chat for in case there is a sync issue for people with the slides. Okay, so and Marilyn, in terms of what time is the break, it's in about 13 minutes. Okay. And I see Stephanie saying that Plural is a good app for clients to keep track of their parts. Okay, I haven't used that, but thank you for that. Okay, and thank you for this. Okay, let me move up here, see if there's any that I can't see. It keeps moving me down the screen. Okay, let's see. Yeah, these are. Yeah. So Margaret was asking, okay, how do I work with a client who has a protective part who will not allow her to find self-compassion? I've asked this part, step back into a waiting room and observe, but the part will not stay in the waiting room. What to do? Super important. Couple of things. In some systems, it just doesn't feel safe yet for the protectors to allow the person to feel that compassion for themselves. That itself does not feel safe. And where I've seen that a lot actually is in systems where people have been tremendously abused and they were in very unsafe situations growing up. And in those very unsafe family of origin situations or other situations, when they showed qualities that we would associate with the self, when they showed things like curiosity and compassion and confidence and feeling good about themselves in any way, they were punished more. They were actually punished more because it's hard to control someone who's feeling good about themselves. So in these abusive situations, any of those qualities that we associated with self were actually kind of stamped out. So it became safer, to not feel those things, to not feel good about yourself, to not express curiosity, confidence, compassion, in the case of one client in particular, any sort of compassion that she expressed toward anyone or anything resulted in very, very negative consequences for whoever or whatever she loved. And so it was just dangerous. And so if that's the case, we really respect with the protector, okay, it doesn't feel safe yet to you to allow, compassion, even self-compassion, compassion for other parts to come through. So that's okay. We're going to stay with you. So you would stay right with that protector instead of asking it to wait somewhere else. You would stay right with it using the techniques we'll talk about in the afternoon and form a really deep, respectful relationship with it, between it and the client, so that that protector can help the client get why it doesn't feel safe. And slowly over time with that relationship, that starts to open the door. It's a lot to say like how, but I'll just say that starts to open the door. So you would start with the part. And the other important part of your question is anytime you have a protector that maybe you've asked it if it would be willing to give space or, wait somewhere and observe, and it keeps coming back, it's an indication to stay with that part. It's just not comfortable. It just doesn't feel it's safe to allow us to do whatever we might be trying to do here. It's not feeling safe. So it's going to keep jumping in. So then we say, that's fine. And that part becomes the one that we hang out with. And it tends to go a lot better. So yeah, thank you for that. Okay, so let's do a tiny bit more. I want to say a little bit about burdens before we go on our break. So we have a lot of different parts in our system. Nobody can say how many. Dick Schwartz used to say, I don't know if he's still saying this right now, but in the course of working in therapy with a client, you may work with between 10 and 30 different parts that they have, but they can have more than that. And not all of our parts are wounded. Not all of our parts have burdens. Some of them are just existing, like my organizer I talked about before, in the preferred role. I will say my organizer used to be quite a burdened part. And it took some work with me and her for her to feel safe enough to not be in a much, much more extreme place than she is now. Now she's like happy and functioning and doing what she loves. It was different. It was different in the past. So some of our parts are just existing in an unburdened way and lending all their wonderful qualities. But for those who have been wounded, they can take on what we call burdens, which are defined as negative or extreme emotions, negative beliefs about themselves or the world, negative energies. And these burdens, these negative beliefs, these negative emotions, these negative energies that the parts take on arise from the meaning that parts make of external events. So what that means is something bad, let's say, happens to a child. And if there isn't a safe and supportive and loving adult there to help soothe the child, help them make sense of what happened, the child's going to make their own meaning out of it. And kids developmentally are naturally egocentric. It's just where they're at, right? So the meaning that they make is going to be about them. So somebody hurt me, I'm bad. Mom never wants to talk to me. I'm not lovable. If I were lovable, if I were good enough, she'd want to talk to me, and she never talks to me. A child 3, 4, 5, 6 years old is not in the place yet where they can give themselves accurate context. They can't say, Mom has a pretty severe trauma history. She loves me. She's doing the absolute best she can. But sometimes, her body's in a state where it's just not feeling safe and she can't connect from that place. And so it looks like she doesn't love me, but it's really about, what she's going through. And it isn't personal. Like, what 4-year-old can do that? It's hard for us as adults to actually be able to really get why somebody's being a certain way with us. It just hurts, So for a child, it hurts. And the sense they can make of it is it's me. So the distinction between a part and a burden is an important contribution of IFS, the idea that the part is not the burden it carries. This, because Dick Schwartz said one of our culture's biggest mistakes, and even in psychotherapy, has been to confuse the two and try to get rid of them both. So saying, this is my low self-esteem, I must get rid of my low self-esteem. No, this is a part of us, a wonderful person inside of us with a lot of great qualities, who feels worthless, who's been made to feel like they don't matter. And if we can help them release that burden, that belief, that energy of I don't matter, I'm not important, if we can help them release that burden, then they're just a wonderful person inside of us, wonderful subpersonality inside of us that can lend all these great qualities to the system. So we will talk in the afternoon about the process of unburdening, helping parts release the burdens that they carry. Let me just check a couple more questions. Yeah, this is so important. So I wonder how a significant life event like grieving the loss of a person or loved ones, and the question disappeared. Hang on. And impact the exile firefighter manager. I can imagine it depends on the life situation, but wondering if you could speak to the heightened state significant life events can place on the parts of ourselves. Yeah, whenever we go through something, enormously painful like that, let's say we're in a place where we feel comfortable with grief. Like, let's say we can feel our pain, we can have compassion for ourselves as we move through the grieving process. We can stay open to the waves of grief that come. We can get social support from others. We're connected. In that case, we're probably not going to exile anything. We're probably not going to take the parts that are hurting and have to put them away somewhere because it's too much to handle. We'll just go through our healthy grieving process. But if we don't have that, let's say we don't have anyone supporting us around us, we've got all kinds of other stressors going on, or it doesn't feel safe inside to be with strong feelings and lots of pain. That feels activating, like, oh, I can't be with this, like I can't feel this, I don't want to feel this. Then it can get exiled. Then the parts that are hurting, that are grieving, that are reacting to the life event could get exiled. And whenever we have stuff that protectors don't want us to feel, that's when the protectors get more extreme because they're trying to keep us from feeling all that. So that's when the managers can try to control all the situations so that we're never reminded of that, so that nothing triggers that, and then it gets triggered anyway, and we start to feel all that pain or that anxiety or whatever. And then the firefighters are using all their methods to get us to disconnect from it. So it all depends, like you said, on the situation. Is it one thing that's going on? Is it 5 things going on at the same time and it's just too much? Do we have the support we need? Are we able to be with what's coming up for us? Or do parts not trust that it's safe for us to be with what's coming up, and therefore they're trying to protect against it? And yeah, this is another really interesting question. Yeah, some people are asking about CBT, and yes, CBT core beliefs are very much what we're talking about with burdens. It's a very powerful thing. And somebody was asking about using IFS with CBT, and I can't give a complete answer to that now, but what I'll say is it's really interesting that when a client is connecting from their self to a part of them that holds certain core beliefs, the kind of changes in thinking about themselves and the world that we might try to implement with CBT happen very organically through this self-to-part connection. So maybe through CBT, we might have been trying to assist them in shifting the way that they're understanding things and perceiving things. And it's a form of like counteractive change. Like, you've got this core belief and we're going to help you to be able to think about this in a different way that sort of competes with the original belief. And here, where we go in and we are connecting with the part that's holding that belief and doing through the relationship, this healing work, it's like the story starts to change organically and they get to the same ending point, but in a way that doesn't feel like they're trying to overlay a competing belief on top of the original, but in a way that it's like, whoa, the original has changed. And so it's I don't know, it just feels like the best of both worlds to me, the way that happens. So it seems like some of you have experienced that too with IFS or can relate to what I'm talking about. So again, thank you for the feedback, so helpful. So we are at our first break time now. So we're going to take a break for 15 minutes, and then we'll come back and move on to the concept of the self.